Hello everybody, welcome to Professor Orthodontics, your online classroom to understand orthodontics in simpler terms. Today's class is going to be on interproximal stripping, also called as enamel reduction. This is basically a continuation of our previous class, which was on circumferential supracrustal fibrotomy. Circumferential supracrustal fibrotomy, interproximal stripping, together can be used as an agent to improve retention and decrease relapse following orthodontic treatment, along with the conventional retention regime. So, in individuals where the chances of relapse are higher or the relapse can be predicted, these two methods can be used as an adjunct to increase retention along with the retainers for the patient. So, let's start learning interproximal stripping or enamel reduction. IPR is also known as slenderizing, disking, and when the same procedure is carried out with the help of Airotor and BURS, it's called as ARS or Airotor stripping. Over here in the right corner, we have an example of a BURS which is used for IPR. Now this is a Strauss burr and this is a unique shaped burr which is needle-like. There are some other burrs available. They may not be having exactly the same shape, but they are more or less conical and long needle-like. So when do you advise IPR? We can advise IPR to increase retention after orthodontic treatment and decrease relapse. Yes. But this is not the most commonest indication in orthodontics. The commonest indication is creation of space to carry out orthodontic correction. Say it's a mild crowding case, or say it is a very mild flared incisor case. In such cases, if the space required is not excessive, extraction would be too much of space. Extraction will result in excess of space, and losing that space will increase the duration of treatment. So, in such cases, we can instead go for IPR. There are some other rare cases wherein IPR may be indicated. One example could be in adult patients where there is excess of gingival recession. The interdental triangular zone due to recession of gingiva may end up with black triangles, or even in young individuals where the tooth is very triangular in shape, there may be presence of black triangles interdentally which are very unaesthetic, particularly in the incisor region. So decrease of triangles, black triangles, can be carried out by interproximal stripping and consolidating the space present between the teeth. There are other rare indications, for example, in cases where already some amount of relapse has taken place and the entire arch need not be treated orthodontically because there is only limited area where there has been loss of retention. So only in that area IPR can be performed to create space, and then only in that area orthodontic brackets can be bonded. Irrespective of the indication, IPR is considered as a minimally invasive procedure to create space. It's a conservative method and a long studies have been done and a lot of research has been done on IPR in the figure G. Apart from that, you need measuring gauges, which we have already seen before. We need elastomeric separators. We need indicating wires, which are either O2 or O3SS or brass wire can be used. And you can use polishing disc to polish the surface, or polishing strips can be used. Before at least a week of IPR appointment, elastomeric separators had to be placed to create space between the teeth. Now this is done so as to adequately access the site where IPR has to be performed. This gives increased visual visual clearance. It also gives you access to the site of IPR. Following removal of the separator, you have to measure the amount of space that you have created with the help of the measuring gauges. Also, before performing IPR, it is very essential that the teeth have already been aligned. This is particularly true in cases wherein the teeth are rotated. So, alignment and leveling should be done before you perform IPR. The reason being, if the teeth are rotated and we perform IPR, following orthodontic correction and alignment, when we arrange the teeth into ideal position, we would realize that we have damaged the contour of the tooth because we have not physiologically contoured the tooth during IPR. If we already align the teeth before IPR, then we can perform the procedure keeping the physiologic contour of the contact point in mind. Whereas without alignment and leveling, when we do the IPR, we may damage the contact point or lose its physiologic shape. We do not want to create box-shaped teeth following IPR. That is not exactly the idea. To the maximum that we can go is that we can widen the interdental contact so as to avoid slipping of the interdental contacts that can happen during relapse. So to avoid that, yes, to some extent we can alter the shape of the IPR by slightly widening the shape of the interdental contact. But we want to maintain the physiologic shape and the contour of the tooth. Churasama and Sheridan use the term beads on a string. So they suggested that don't carry out all the IPR at once and try to carry out IPR from the most posterior to the most anterior teeth. For example, if you're starting from the posterior to the anterior, perform IPR in the molars and the premolars, close the space. Following space creation, perform IPR on the premolar and again close space. It is highly essential, as they put it, it is essential to retain your anchorage and treat the case as critical anchorage and not lose the space that you are creating with the help of IPR. So before you start the IPR, it is essential that you enforce a good anchorage in place. Either you use a lingual arch or a nance palatal arch or a TPA, but make sure you have an anterior posterior anchorage in place so as to avoid loss of anchorage. So say there's minimum amount of IPR required. In that case, abrasive strips can be used to perform IPR. They are all in different grades: fine, medium, extra fine. So what we can see is a manual type of IPR in the picture. This is particularly done where lesser amount of IPR reduction is required, particularly in the anteriors. The movement of the abrasive strip is usually sawing like motion. So with the help of sawing like motion, IPR is performed and it's done from occlusal to the gingival direction. This has to be continued in a slow motion and intermittently with the help of measuring gauge. The amount of IPR done is to be checked so as to not overdo the procedure. So if we want only 0.5 mm of space, we have to make sure that it's only 0.5 mm of enamel that we are removing. We do not want to remove excess of enamel. We want to maintain the procedure as conservative as possible. So the strips are placed interdentally and sawing like motion is carried out. If it is a one-sided abrasive strip, then after some amount of sawing, the strip is turned inside out and the other side of the contact is also stripped. Now, this procedure is continuously done with check with the help of the measuring gauge. Now, the advantage of this procedure, it's very conservative. The disadvantage is that it needs a lot of time and it is very difficult to perform the same procedures in the posterior because of lack of visibility, lack of access, and these films are usually very cumbersome in use because they are flimsy, they are not very stable, and they are strip like structures, so they cannot be used very conveniently in the posterior region. There is also risk of trauma to the interdental papilla when using the same strips in the posteriors. So instead of abrasive strips, we can use mechanical methods like BURS, which is also called as Airotor stripping. There are other devices available like discs. We have we've already seen the BURS. Now these are the discs that can be used. These are attachments which are to be fixed onto the disc so that they don't damage the disc does not traumatize the tongue or the cheek or the interdental papilla, etc. These are different kind of attachments which are available. These are reciprocating. These type of attachments usually are reciprocating types. These are oscillating types of attachments. So these are mechanical motor run devices which are used for IPR. Particularly useful when more than 0.5 mm of IPR has to be performed, and in the posterior regions, these provide better access and better visibility and control. BURS can also be used for the same procedure. Now, the disadvantage with BURS is that if there is improper control during the use of ARS, there is a chance that you may form furrow-like indentations on the enamel surface due to improper placement of the or angulation of the burr tip. Now, to avoid this, non-cutting tip, also called as safe end tip burrs, like the ones that are used in endodontic access opening, just like that, even in interproximal stripping, safe-ended or safe-tip, non-tip burrs, non-cutting tips burrs are available for IPR. So they can be used, and by doing this, you can avoid forming those furrows or dents on the enamel surface because those dents are difficult to remove even after polishing. What we see is on the left side, these are the advanced devices, most advanced technology available currently to perform IPR. So some studies have shown that of all the devices available, the devices that use reciprocating motion or the devices that used in and out motion. For example, over here we have bifroprofin. So these devices are they are very precise in their action. So by using these devices, you get better control. There's a lesser risk of over reducing the enamel surface, and they are available from fine to medium and extra fine, different grades. Now these profin cutting tips are available in almost 15 different grades, and they advocate use of the most coarse to the most fine, and in certain areas they may not enter directly. So in such cases, instead you can use the cutting burrs at first to open the contact, and following that these attachments can be used to perform IP. This particular attachment is the oscillating type, and this is by Brotec. So over here we can see the movement, the angle of movement of this attachment is 60 degree. So it moves only up to 60 degree. It can be used over here in the lingo buccal direction, okay, with constant water cooling. So what are the steps? Whether you use abrasive strips or you use burrs or you use oscillating disc, the steps remain the same. First, you need to place separators to open the contact at least a week prior to the procedure. Measure the space that you have created with the help of measuring gauge leaves, and then add the amount of IPA that you need to perform to that measuring gauge. Say that after using a separator and opening up the space, you have created a space of 1 mm and you need to perform an IPR of 0.2 mm. Then in that case, after you measure with the gauge, you check, okay, fine, you have 1 mm of separation between the teeth. And then you have to keep performing IPR until you get 1.2 mm of space. So you have to add that IPR measure that you need to perform to the gauge and keep checking the amount of IPR that you're performing. Make sure that you do not damage the interdental papilla, so you can use a wire just below the burr or below the disc. It should be placed interdentally above the interdental papilla so as to avoid damage to the interdental papilla. So either you can use a SS wire O0, O2 or O3, or you can even use a O2 O3 brass wire. Once we have broken the contact, As soon as we have just nicked the interdental contact, run the floss through and check if you have cleared the interdental contact. If not, carefully perform the procedure a little more until the floss runs occlusogingivally easily between the teeth. After this, polishing can be performed, and following this, topical fluoride can be applied. Sheridan said that up to 50% of one enamel surface can be reduced during IPR. That's almost 0.5 mm per surface. Going by that measure, in the anteriors, you're getting 2.5 mm of space. In the posteriors, you're getting 6.4 mm of space. So overall, you are getting almost 8 to 9 mm of space just with the help of IPR. He advocated the use of light whipping strokes and use of water cooling to decrease the amount of heat that's generated, because we do not want to damage the pulp during IPR. Obviously, it's a mechanical procedure, so that results in heat production, and we don't want to damage the pulp during IPR. Zacharson instead said that instead of using water cooling, we can use air cooling. And by using air cooling method, we are also improving visibility, because when we use water to cool the surface, obviously some amount of visual access is impeded, and we can avoid that with the help of this. So what if we just stop after IPR and we don't go ahead and polish the surface? It is very important that IPR is followed by polishing of the surface, because IPR results in increased enamel irregularities. These enamel irregularities result in increased plaque accumulation. The surface becomes extremely rough. We know that enamel is the strongest part in the whole human body, and we also know that the outermost surface of enamel is the strongest of the whole of the enamel. So we are losing the most mineralized part of the enamel by doing IPR. Now, this is not that big a deal if precautionary measures are taken following IPR. That is, if we do polishing of the surface, if we apply topical fluoride, then the enamel surface remineralizes itself and heals completely, and there is no long-term risk of any problem, including risk of dental caries or gingivitis or periodontitis or sensitivity. Whereas, if we just perform IPR and leave the enamel surface just like that, the rough enamel surface attracts food, debris, causes plaque accumulation. That accumulation will result in A. Increased caries risk, B. Gingivitis. Gingivitis, if not treated, results in periodontitis. Dental caries and periodontitis, which is associated with gingival recession, will result in hypersensitivity. So one incomplete procedure can result in many other problems. So we have to make sure that after IPR, we perform some kind of polishing, be it with the help of Soflex disc, be it with the help of abrasive fine polishing disc for polishing strips. It does not matter which method you use. Make sure you perform polishing after IPR. So you can use diamond polishing burrs, you can use 3M Soflex discs, you can use abrasive strips, fine abrasive strips with 35% phosphoric acid impregnated onto it. So Tortella conducted a study and found that after IPR, the surfaces that have been polished with acid impregnated proximal strips were found to be much more smoother than even the natural enamel. So that's a great advantage of using acid impregnated strips following polishing. So ZHONG conducted a study and he came up with a 3-step technique. He used oscillating discs like the one which we've already seen by Brotec, and he found that the current systems, oscillating systems which are used for IPR like Profin, Ortho strips, and ODrive D30, they were studied by Danish and they found that they are most beneficial for IPR because they leave surface less damaged when compared to the other methods. Of course, they need different handsets altogether. Most of them have a different system of handpieces which are required for them. Now, the study that was done by ZHONG proved that the oscillating perforated diamond coated discs were much better than the others that were available. He used the disc with two softlex discs for polishing. So, with the help of that, he found that the surface was well polished, patient was comfortable. He carried out SEM studies and he found that the enamel surface was extremely polished with the help of this three-step system. And the patient was also comfortable. No lip injury or soft tissue injuries occurred during this process. Along with this, many studies have shown that application of topical fluoride is beneficial. So either topical fluoride or fluoridated toothpaste along with fluoridated water consumption are advocated. So Jarjora conducted a study, Jarjora and others together studied and found that those individuals who are already consuming fluoridated water and using fluoridated toothpaste did not significantly benefit from topical fluoride application. So if you are already consuming fluoridated water and using fluoridated toothpaste, then topical fluoride may not be very essential, not significantly essential. But then in India, community water fluoridation is not present, and most individuals do not prefer using fluoride toothpaste. So in a country like India, it would be better that topical fluoride is applied after IPR. So a similar study on prevention was done by Giulio, and they found that the GC moves like substances which contain casein phosphopeptide amorphous calcium phosphate when applied for at least 5 minutes on the surface which has been subjected to IPR will result in increased resistance to caries. So some kind of remineralization has to be performed. Either it's topical fluoride or it's GC moves. Either ways, we have to try to remineralize the enamel surface as fast as possible. Even Profit supports the use of topical fluoride to increase remineralization following IPR. So we've learned so much about IPR. The good things about IPR is that it's a very conservative method of creating space, and yes, it decreases the duration of treatment instead of say it is a moderate, very mild case of space requirement. In that case, you need not extract the tooth. Whereas if it's a moderate to severe case, obviously extraction of tooth is the only way out to create the space. So in a very minor case, it decreases the duration of treatment and it's a very safe method of creating space. But then there are drawbacks also. First drawback is that it cannot be used as a sole method of creating space and during orthodontic treatment. It is better if you use this process as an adjunct to create space. In the sense, this should be used, IPR should be used along with arch expansion, dento-alveolar expansion, or skeletal expansion to create space, and it should not be used as the sole method of space creation. Second thing is, it is better to be as conservative as possible. Yes, according to Sheridan and according to many authors, you can create almost 8 to 9 mm of space with the help of IPR only. But then Hudson has already shown that the size of the tooth is not directly proportional to the amount of enamel that is present. So it's very difficult to say which area has more enamel and which area has less, because it may also vary from one individual to another. Fillion particularly said that in the lower incisors, it's better to not remove more than 0.2 mm of enamel. So the safer, the better. Try to remove enamel with IPR as less as possible. That's the reason why it should not be used as a sole method of increasing space to carry out orthodontic correction. Instead, it should be used as an adjunct to create space with other methods like arch expansion. So with this, I like to conclude that long-term studies have already been carried out to study IPR and its effects. Zacharison particularly carried out long-term studies and he found that despite after many years of following IPR and orthodontic treatment, no harmful effects were seen on the health of the tooth. So when IPR is performed properly with all the other precautions as we've already learned, There is no harmful effect whatsoever on the tooth. So that's it for today. I hope you enjoyed your class on interproximal reduction, also called as Airotor stripping. If you like this channel, please subscribe, and if you have any questions or any suggestions, please drop them in the comment section below. Do remember to like this presentation. Thank you.